Good morning. This is Ramesh DAGGUBATI. I'm assisting Dr. Ömer GÖKTEKİN in Turkey for Euro-PCR. We have a patient who has a CTO. We do not have any conflicts of interest. Next slide, please. So here is a male 60-year-old with the diabetes and hyperlipidemia as the risk factors, and he has past medical history of lung cancer. He's undergoing chemotherapy actively. Next slide. He has a class 2 to 3 angina, and in January 15, 2016, he had a coronary angiogram that showed a 3-vessel disease. And because of lung cancer, he was referred to PCI and was refused by surgeons. The lab workup is unremarkable, and as you can see on this slide, EKG actually shows some ST depressions with negative T waves. Next slide. So here's the angiogram. There is an injection of the left coronary artery that shows a proximal 100% occlusion of the circumflex artery. And there is a LAD that has a proximal maybe 40 to 50% disease. Next slide. And the right coronary artery, as you can see on the slide, is 100% occluded in the proximal portion with a very ambiguous cap. And it is filling via retrograde collaterals from the LAD through the septal perforators. Next slide. So the important points today and strategies would be what are the techniques for this CTO, whether we should consider antegrade or retrograde, and if it is what wires, and what kind of microcatheters. Next slide. So the necessary materials will be guiding catheters, obviously, whether we have to use intravascular ultrasound and microcatheters, and even sometimes guide liners or Godzilla type of devices to deliver the stents. A bilateral transradial access with 6 French slender glide sheets made by Terumo, and we introduced from the right radial a 7 French EBU 3.5 launcher guide catheter that was used to cannulate the left main artery, and we have a 7 French JR4 launcher guide catheter from the left radial, which is used to cannulate the right coronary artery successfully, and we have taken an angiogram with the dual contrast. Okay.
Go. Okay. So
it's a short 15 millimeter, but ambiguous proximal cap.
you see here, the right coronary is occluded at the proximal, and there is no actually antegrade flow.
Right.
We see some vessel there, but I believe that is not right coronary, it's a vein.
It's a venous filling.
Yeah. So do you agree with me?
I completely agree. It's a
Yeah.
venous filling. We can see
Yeah.
that it's draining into the coronary sinus.
Yeah. So there is no any actually filling from the proximal to distal RCA actually. Okay. Then we have stenosis in this patient. It's moderate stenosis in the LAD. We would like to see that, and we would like to treat if necessary. Yes, please. Okay, I don't think it's a severe one. It's less than 50%.
Yes.
What do you think?
I think it's about 40 or
40,
so.
yeah. So I think we don't have to treat this
Right.
actually. And if you go to left, please, we will do a bilateral injection now.
Yeah.
Okay. So the occlusion is around 30 centimeter
Right.
up to mid RCA.
Yes.
So what do you think, Ramesh?
I think in this patient, there is an ambiguous proximal cap, and we don't see anything from the antegrade. And we have to consider both the techniques, the antegrade, whether dissection re-entry, or a retrograde, which would be from the LAD. There's a beautiful septal perforator,
Right.
and I think this patient actually would benefit from doing a retrograde CTO.
Okay, let's come to right then. Okay. Okay, see that? Okay. There is a nice collateral from
The first
septal and maybe second septal, but
Yes.
I think it's better to check which is better.
Yeah.
Because in here I'm not quite sure which collateral is best. I think the first one is good, but it's
Right.
better to do some tip injection
Right.
before doing that. Okay, can I have Corsair, please?
Yeah.
Are inserting Corsair with BMW Can I see the proximal? Yeah. And then we try to engage the septal artery, the first septal, and then we will do a tip injection here. Test, please. Yeah, record it, please. So, I would like to introduce this,
Yes.
but I would like to.
And we want to be in the second branch of that first septal.
Yeah. So I will a little bit come back,
Right.
and then this
Right.
one.
I
Right?
think, yeah, that's
Okay.
the one.
So we'd just like to do some tip injection here
Uh-huh.
to see where are we going.
Right. So take the.
And yeah, to do tip injection,
Mhm.
can you show me my hand, please? Can you show me my hand? If you see here, while my colleague removed the wire, I just feel it to reduce risk of air embolization. And I pull some blood. It shows me that I'm not in the tiny septal, so I can inject here, right?
Yes.
Okay. Okay, so I think, what do you think, Ramesh? We have a nice
Nice
collateral,
channel.
right? One of
Yeah.
them will go there. Let's
Definitely.
surge
So
these
se-
septals.
Yes.
Sion, please. Now we are having a Sion.
So we're going to do the septal surfing through this first septal.
Yeah, actually,
perforator.
I mean, to be honest with you, it's not that clear, but
Yeah.
I'm sure we will try. There are 3 septals there.
Right.
You see here. So we have to go, I believe, middle septals.
Mm-hmm.
We gave him the heparin, full dose heparin now, and we will check ACT in 5 minutes. And we try to keep ACT higher than 350.
Yes.
Ramesh, yeah?
Right. Yeah.
So this is a retrograde case. So we use both.
Yeah, whenever we are using large equipment and maybe the time duration of the procedure may be longer, it's always good to anticoagulate effectively.
Yeah.
So see the beautiful
Yeah.
technique of
Record
Ömer
it, please. Yeah.
in
So,
advancing the
yeah.
Sion.
Yeah. We actually go somewhere.
And now you should see how the corsair is being advanced
Right.
slowly.
So, and then if we go to left now, try to go a little bit higher. Yes, now we are in the middle LAD, yeah?
Yeah, so that's probably a marginal branch.
Yeah. I did it on purpose because I like to introduce my corsair more. To do that, I need support
Right.
of the wire. So I just insert my...
And also going into
Now,
the branch
if
helps you
look
that
my- yeah.
in the true lumen.
Yeah, if you look my hand,
Yeah.
how I insert it, I'm rotate it, and also I'm insert it.
Right.
Okay, now I think we are in the distal of the
Right coronary
right
artery.
coronary artery. Just try how it goes. I like to push a little bit more
Mhm.
to take that curve.
The guide
The
catheter.
guiding is coming
We
back.
keep an eye on that.
Yeah.
Mhm.
So
Sometimes you need 2 people, one to hold the guide catheter.
yeah. Okay.
Okay.
So now I like to change my wire
Mhm.
to actually I like to have Gaia second here.
Gaia second. Mhm.
What do you think, Gaia second?
So can
Or-
you tell the audience why Gaia second
Yeah.
versus
Yeah.
ultimate or
Yeah, I think I also could use ultimate 3 here.
Mhm.
I like that wire as well. But what I'm thinking, I will, there's a nice tapering channel retrogradely.
Mhm.
So I like to engage that one and try to inside the CTO with Gaia
Yeah.
a second, hopefully. Gaia second has original curve, if you see us, can you focus here?
So there is a pre-shaped short 1 millimeter
Yeah, 1 millimeter.
bend of about 45-degree angle.
Okay. So now I am inserting with Gaia.
The patient's blood pressure is stable at 144/79.
I like to comment a little bit back. Blood pressure is nice.
Yeah.
Try to knuckle.
Mm-hmm. Gaia second has a good torque control and
Right.
also penetrable power.
Yeah, I will insert it slowly.
Yep.
I don't need to be rush. I need some more Corsair Sport.
Mm-hmm.
I'm pushing my Corsair slowly. I have to push my Corsair slowly because I'm using septals, so each systole
Mm-hmm.
keeps the Corsair fixed, right? So
Mhm.
I have to respect that. That's why I cannot push.
Right. It's better to do it with
Yeah.
each respiration and
Yeah.
heartbeat.
Yeah.
Now you can see we are slowly advancing towards the proximal RCA. We don't have any PVCs on the monitor, suggesting that we are still in true lumen and not coming out. And
Yes, that's true.
yeah.
I'm pushing a little bit more Corsair.
Mhm.
Yeah, to have more
Yeah.
support.
More support. Yeah.
And
And here we have to.
can I see
poke.
some antiload flow from our RCA?
Okay.
Yes, please. So direction is not bad.
Right. Mm-hmm. And we essentially have to poke the proximal distal cap and then the proximal cap.
Yes, as you see,
And
Gaia moving slowly, right?
yes.
Goes
Mm-hmm.
slowly, right?
Yes. Yeah.
When you use Gaia, you have to be more patient than when you use other
Right.
wires.
We try to be in the true lumen
Sure.
and not actually do a dissection here.
Sure. Test, please. Now I'm trying to be a little bit down. Yeah.
Right.
Test.
You want to fluoro save that? And
Test, please. test. I'm subintima, I think.
Mm-hmm.
I am just subintima.
Probably,
What
yeah.
I want to do, I like to do the comeback
Yeah.
and puncture from another place. Okay.
Do you want to take in a different view as well? And
No, that's okay. I'm
uh-huh.
pretty sure. Where am
Right.
I?
Yeah. Okay.
Now I'm test. Okay, now I'm different.
Different channel.
I mean, yeah, different platform now.
Yeah. Mm-hmm.
Test, please. But still higher.
Yeah.
Why don't we should come back a little bit back and try to puncture somewhere else. Okay, so I think what I can do, I can have now here.
Would you use a pilot 200 in this scenario?
Not here,
Mm-hmm.
because I have to have something I could torque.
Right.
Yeah, in pilot I cannot much.
Mm-hmm.
And I have already subintimal space there. Test, please. Okay. Now I will change my wire to Miracle 6. 6, yeah. Because now I see the distance is not big, right? Around 20 centimeter, and I will have a nice curve, and I will. Now I am inserting Miracle 6 to exactly to go to the ostium of the RCA. Test, please. Test, please. This wire also tried to went to same channel actually. So
Yeah.
I have to have another path from the distal. Now we have ACT 278. We will give 3,000 more heparin here. BMW. I like to have one BMW and okay.
Okay.
What do you think? Shall I come a little bit back and
Yes, I think maybe pulling the crosshair back a little bit and
then try to find another path, really?
yes,
Yeah.
exactly.
Now I'm touching something different.
Mm-hmm.
I feel that.
And the path also appears to be slightly different than before.
Yeah. And I'm pushing my corsair to have better support because I feel the resistance there. Different part of
The
the
distal
CTO.
cap. Mm-hmm.
But now I'm in the same path, I think.
Right up
I
there.
feel that. Yeah. I just jumped to the same. So I think, Ramesh, it's time to do a reverse cut here.
Mm-hmm.
What do you think?
I think yes. I think
Yeah. That will be our life make easy,
yeah. Mm-hmm.
I think. This is another one, another path.
Mhm. Yeah, now it looks like in a different path here.
It looks like,
Yeah.
to be honest.
Mhm.
Uh-huh. Test, please. Different. This is for sure a different, little bit different one. So in here, if you want to, I like to change my wire to now Miracle Ultimate,
No.
because now I'm in this different path, and I'm hoping that this wire will go directly in the RCA. That's good.
So Ömer, you pulled out the Miracle Brothers 6.0, and we are advancing Ultimate 3 through the Corsair now.
And I feel that I'm in a different path. And if this doesn't work, we will do reverse card immediately.
Right.
Can I have a test, please?
So our total fluoro time is 18 minutes so far.
You see, it's jumped that part
Into that,
again.
yes.
Yeah, it's jumping somewhere.
Right there, I think.
Like here. Yeah, I have
Uh-huh.
to go a little bit this. Yeah, here. This is. I'm in the. Yeah.
Yeah.
Now I'm in the. I know that I'm in the aorta.
Mhm.
Then I try to engage my wire again. Test, please. Test, please. Test.
Yeah.
Okay, but actually it's aorta, but it's out of the vessel. I don't.
Yeah.
Shall we snare these or try to do reverse card? What do you think?
Yeah, we can snare this, I think.
I think you're okay, yeah, with snare, yeah?
Yeah. Mhm.
Yeah? Yes, you are right, huh?
Yeah.
Okay, let's snare it. I like to insert my Corsair into the RCA to insert RG3 here.
I have to go. Okay.
Just a second. Direction.
All right.
Just, yeah, you can, in 5 minutes you can leave, yeah? Don't worry, the traffic is, there is no traffic,
Yeah.
don't worry.
Mhm.
Can I see from the right?
Yep.
Now we are snaring the vessel.
Yeah. We're going to snare that ultimate 3 we have.
So now we are trying to snare it. Now I snare it.
Oh.
Yes, more. This time. Okay. Push it.
That's the maximum that it can
Okay.
go. Okay.
Okay. Leave it like that.
Okay. Okay.
Uh-huh.
Okay. Guide. I'm gonna have to go.
Okay.
Thank you.
You can go. So, unfortunately, Ramesh has to leave now to
Sorry.
catch a flight. But I think we will do
Yeah, you have.
most important part of the job. Thank you
Thank you very much,
Ramesh,
Ömer.
for
Pleasure
helping
working
me.
with you.
Thank you very much.
Thank you
Bye-bye.
very much.
Can I have RG, please? RG, please. Now I'm removing here my stiff wire, which is miracle here. Then I will insert RG. Now I'm inserting RG to snare this one. Now, as you see, I catch the wire. I will have it inside, and then just I insert RG, and I'm pulling back. Okay, so, and I will cut the RG from the proximal part. Makas alabilir miyim? So now, you see now I have because I snared the wire, I have this ugly shape. It's better to cut this one. Okay, now I have the loop wire with my hand, two hand. You see, on both I have two wire. It's looped wire now, so I have to insert my retrograde wire to RCA. Now I have to insert my guiding into right. Can you keep it, please? My colleague, keep the other. Can you keep both of them? Yeah, just hold them. Okay. Can I have some injection from the right, please? From the right. Okay. So I want to insert a balloon here. Yeah, I'll start to dilate from here. 2O. 2O. 14, 15, 16. Good. Down. 2O. 14, 16. I like to have IOs here. 17, 18. Down. 14, 16. Down. I'd like to have 2.5 by 20 NC balloon, please. This is NC balloon. Down. 2.5 by 12. 15. Down. Down. Go. Down. Up. 14. 16. Down. 16. Down. So now I'm doing IVUS examination here. The main reason is I have two reasons to use IVUS here. One, stent size, and the second, where should I put the stent at the distal? Because I don't want to give any anticoagulant injection here, because I was in the subintima in somewhere. So it's better to do IVUS to the side. I'll go down, I will pull back. Okay, now in here, vessel looks not bad. There is some disease part here. The size of the vessel is around 3 point actually, 3.0, 2.8, 3.0. And I come back to the bit. Now my wire is in intima, in trulumen, you see. There is a very calcified lesion, which is from 3 to 7. And I come back. I'm still in trulumen. And now I am subintima, right? From there, my wire went to subintima. You see the trulumen from 12 to 3 o'clock. Yeah, there's a side branch here. There's calcification from 9 to 11, 9 to 1. And here, I'm trulumen. Okay, so in the proximal part, the size 1, 2, 3, 4. So what I want to do is insert a 3-point long stent here, and to do post dilatation 3.5 and at the ostium 4. From caudal, can we come from caudal? Test please. So from right caudal, the left caudal, I see better ostium. Very gentle, very gentle. Yeah, okay, not much, gentle. Okay. Okay, so I'll implant my stent here. Go. 10, 12. 12. Yeah, the expansion atmosphere is 12. We will wait for 20 seconds. After implanting a stent, I could give anticoagulant injection, because I know that I see a little dissection part. So I like to give some nitro here to see what I will do the down. Okay, so you see that after nitro, the distal vessel became bigger. I don't want to put any more stent down. I think I'm okay here. There is some disease part, but I don't want to put another stent there. If I need it, I will do it later. I mean, after 6 months, I will check this lesion. So as you see here very clearly, this vessel is large vessel. So I will post dilate this vessel up to 3.5 and 4.0. Okay. Now I'm post dilate by from the mid RCA. I post dilate by furrow. 12 12 14 down. 12 14 down. 12 14 down. 12 14 down. Yes, 12 14 16 20 down. So our ACT is now 2.98 300. We will give some more heparin because we also do IVUS here. That's the big difference before and after CTO recanalization and stenting. Now the distal vessel is so huge, but before it was very collapsed. Now here we have actually 3.3 vessel here, and I come back to the, I'm pull back now. I am pulling back. Now there's calcification, but the size is okay. It was so narrowed before the stent, and now stent well expanded and well opposed. Yes, just 1 millimeter to aorta, which is the way I like for osteal stent. I think as IVUS shows us, we don't have to put any another stent to distal, and also the expansion of the stent valve. So I don't want to do another post dilatation here, right? So now another things to do is remove our wire, RG wire. Before do that, I would like to have some more image. Left cranial, please. Okay. For sure, there is a disease part. I am not sure what I do. There is a disease part there, although I will show us nice. Can I see from normal left? Left. I like to have the view from the left again. Yeah, there is some spasm there, I think. Let's do a nitrate. Okay. I didn't see much in the IVUS actually. So as you see, we have some narrowing, but we didn't see that. We didn't see that in the IVUS. I believe that is a spasm. So I gave some nitro, and we will check that again. You see, it's spasm. So I don't want to put anything here. I like to remove my wire now. To do that, now I insert my corsair up to distal of the stent. I just remove my wire, but as you see, when I remove my wire, corsair goes up, so I have to remove it very slowly. And if you see my each diastole I can pull it. Now it's better. Yeah, I can remove it faster. Okay. So of course, before removing the wire, I will see the septals to see if there is any damage. And I want to see septals now from the right. So septums are okay. Okay. Okay, thank you very much for attending us. We did a retrograde RCA case today. We used first septal collateral after TIF injection of corsair to see the better branch of the septal. And first CNY could cross the collateral very easily. And after that we choose Gaia second to cross CTO body. It goes up to it went well up to proximal part of the occlusion, but then we had stuck there and we had to change our wire to Miracle 6. Miracle 6 also go there, and he went a little bit he went subintimal space, and lastly we had ultimate 3 which goes to true lumen at the proximal part, and we did snaring of the wire. After snaring of the wire, we insert corsair into the aorta, and we remove the ultimate 3 wire, and we replaced that one by RG3. And after RG3 we had a looped wire, and we just work over on it. We did predilatation by 2.0 to compliant balloon, 2.5 by 12 non-compliant balloon. And after we put a long stent, 48 millimeter stent, and it was 3.0, but we post dilate that one by 3.5, and at the proximal part we post dilate by 4.0. And we of course did pre and post IOS imaging, and we see that how distal part became larger after insertion of the stent and after giving some nitro. It was amazing. And we had some spasm in the last image, and we gave another nitro, and we saw that the spasm also resolved. So this is our last result. So thank you very much for your attendance.